Today, we're going to talk about opioid alternatives in the ambulatory settings. Objectives. Number one, opioid pharmacological alternatives. Number two, medicated topical applications, interventional pain management, non-opioid anesthesia, self-care, complementary therapies, rehabilitation therapies, behavioral and mental health therapies. All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to the next session in the opioid series. Opioid series has become one of the most watched series on Dr. Bean, and also one of the most CME earned series on Dr. Bean as well. So thank you very much for your support for that. The discussion today is the review of alternatives to opioid drugs in the ambulatory setting. So it is sort of an outpatient setting, and what are the drugs that can be used other than opioid? So let's start. What I'm going to do, the objective is to first show you various organizations which are recommending pain management cocktails, if you will, formulas, if you will, and then we will go over some of the important points there as well. So opioid alternatives in the ambulatory settings, that is the topic today. I have no disclosures. Objectives. Number one, opioid pharmacological alternatives. Number two, medicated topical applications, interventional pain management, non-opioid anesthesia, self-care, complementary therapies, rehabilitation therapies, behavioral and mental health therapies. And as you can see, pain management outside of the opioid is a vast area. It's a huge area with lots of interventions available and therapies available. So covering them all is impossible for this one session. So what I'm going to do is, number one, show you some references where you can actually go and dig deeper as well. Plus, I would go over the main recommendations that are by CDC. So let's first look at the references. So this is drbeen.com. If you are looking to get access for CMEs, you can go here for the plans and you can then buy a CME plan. Here, first of all, I felt that the Florida's alternatives to opioid pain management, this summary was one of the best summary. You would actually see many other PDF documents with a detail for alternatives to opioid and how to do the pain management. But for a summary, I thought this was one of the best summaries written. So we'll go over some of this later on. Then this is the CDC, non-opioid treatments for chronic pain. And they have a good summary as well, but their table is just this big. This is about it. And then what they do is they go over various more commonly experienced type of pains or syndromes, pain syndromes, and then they talk about how to handle them. So that is interesting as well. For a summary, I believe this is good too. The references are all in this presentation, and once this video is published on Dr. Bean, the references will be in the description as well. Then this is a very thorough, a comprehensive PDF document. It is from 2019. This is called Pain Management Best Practices. And so if you see here, Pain Management Best Practices Interagency Task Force Report. And if I can just very quickly show you the agencies and members involved. So if you see here, it starts from here. This is the chair, then the special government employee members. So they are from healthcare system. They are from Wisconsin, Milwaukee, anesthesiology, medicine, University of California, etc. There is, I believe that Veterans Affairs, Department of Defense, and HHS were involved as well. So this is an amazing book for pain management and for various therapies, various exercises that are done, and various possibilities that can be done for pain management. So this is a very good one as well. I have referred to this in my talk today. Then this is the American Society of Anesthesiologists, and this is non-opioid treatment. And I have taken some parts from here as well. Then we have the CDC guideline for prescribing opioids for chronic pain, although this part is out of scope for today's talk. However, I left the link in here so that for completeness sake, if you are going to go through the links and study, this would be one interesting link as well. Then a little about the acetaminophen, then a little about the cyclooxygenase inhibitors, then what is interventional pain management, and then finally the common side effects, adverse effects of NSAIDs. So these are the references. With this, let's go to my presentation and continue. So opioid pharmacological alternatives. I want to actually show you this from Florida. They say over here, alternative medication advantages can control and alleviate mild to moderate pain with few side effects. Mild to moderate. Can reduce exposure to opioid and dependency. Disadvantages may not be covered by insurance, the therapies, interventions, the methods that we'll see. And secondly, may not be effective for severe pain. And this is something that I would request you to have in your mind today as well. And I see Joseph Warren as well, so welcome. If you look at the CDC's list, in their table, they also talk about, or they present that various drugs and the kind of benefit, how much benefit they can provide. And if you see here, small benefit, small to moderate, small to moderate, small to moderate, small to moderate, there is no benefit for severe pain. So please keep that in your mind. Now, one more point before we discuss this, the analgesic medicines can be classed in three classes. One are opioid medicines, others are non-opioid medicines, interventions, therapies, procedures. And the third one is a combination. It is actually possible for a doctor to have to give opioid plus to have to give non-opioid and create a combination as well. So we're going to start with acetaminophen. Again, the point of today's review is not to go into the mechanisms of these drugs, but actually to familiarize ourselves with the pain management landscape and how a physician, a provider, what tools do they have. So acetaminophen, first-line analgesic. The NSAIDs are also first-line analgesics too. Pain reliever, fever reducer, but not anti-inflammatory, right? So acetaminophen does not reduce inflammation. It can help with pain and with fever. Because of that, of course, it is not an NSAID. Acetaminophen can be effective for mild to moderate pain. Maximum dose is 4 grams per day, and the dose should be adjusted if it is given with opioid analgesics. Now, it can be safely combined with NSAIDs. And when combined with NSAIDs, they both would amplify the analgesic effects that combined will be produced. Now, the risk for the acetaminophen, I think you all know this. The risk of the acetaminophen is the liver toxicity, right? So what happens is glutathione molecule in the liver becomes overwhelmed by the acetaminophen molecules and the metabolites in the liver. So once the glutathione is overwhelmed, then the toxic substances present in the liver will start causing damage to the liver cells. So the risks of acetaminophen include dose-dependent liver toxicity, especially when the drug is taken at high doses with alcohol, because alcohol itself is also adding some work for liver. And now the liver has to take care of alcohol, plus it has to take care of the acetaminophen toxic substances as well. And the glutathione system is completely overwhelmed, or by those with the liver disease. This risk further illustrates why patients should be aware of the presence of acetaminophen in both over-the-counter and prescribed combined medications. This is very important because many drugs, even over the counter, they could have acetaminophen, and a patient might be taking multiple drugs for pain and for cold, and there may be acetaminophen present in many of them. Now, if a patient has liver failure, then the ideal is to just avoid acetaminophen, or if it has to be given, then a dose should be adjusted. Now, one benefit of acetaminophen over NSAIDs, of course, is the less likelihood of the stomach bleeding or GIT damage. The reason for that is that acetaminophen's main mechanism of action is by its action in the brain tissue. And so as it doesn't have a primary major effect on the GIT tissue, it doesn't cause much damage to GIT. So that is an important thing to keep in mind. Next are the NSAIDs, non-steroidal anti-inflammatory drugs. NSAIDs are also first-line analgesics and anti-inflammatory, but we're talking about pain. So they're also first-line pain medications. They can be combined, as I said before, with acetaminophen. So acetaminophen and NSAIDs together are first lines. They are pain relievers, NSAIDs, pain reliever, fever reducer, and anti-inflammatory. So I'm sure that you are aware that they block cyclooxygenase enzymes. Now, cyclooxygenase, we have cyclooxygenase 1 and we have cyclooxygenase 2. NSAIDs can be non-selective. That means they block both the cyclooxygenase 1 and 2, or they could be selective where they only block cyclooxygenase 2. The cyclooxygenase 2 blockers are milder on the GIT. They do not tend to cause as much damage, and they do not tend to cause as much upset of the GIT as non-selective ones do. So NSAIDs can provide significant pain relief during inflammation. Conditions that can benefit are arthritis, bone fractures or tumors, bone tumors, muscle pains, headache, and acute pain caused by injury or surgery. Examples are aspirin, ibuprofen, naproxen, ketorolac, and ketorolac is given for short term, usually lesser than 5 days, but 2 to 3 days. Ibuprofen, a little bit more about that. Analgesic ceiling dose. This is important to keep in mind that analgesic ceiling dose for ibuprofen is 400 milligram. So above the 400 milligram, the analgesic benefit of ibuprofen is not as much, but the chances of causing cardiovascular events increase a lot. So because of that, using ibuprofen for more than 400 milligram in chronic setting is not recommended. However, it is okay to use that in acute settings. So 600 to 800 milligram, even combined with acetaminophen for acute pain, can be used. Now, as I said before, non-selective NSAIDs, they can cause GIT issues, GIT upset, stomach bleeds, ulcers, etc. On the other hand, the cyclooxygenase 2 inhibitors, and in the US, we only have celecoxib. That is the only one that is available in the US. They are milder, they are more soft or tender on the GIT. They cause less bleed, less upset. And these cyclooxygenase 2 are indicated for ankylosing spondylitis, hereditary polyps of the colon, juvenile rheumatoid arthritis in children aged from 2 years, menstruation, and osteoarthritis. So I have a quick question for you. Look at this. Associated with GI injury, NSAIDs, renal insufficiency, hypertension, and cardiac related events. So the question is, what are the reasons? Some reasons. Every tissue has a different set of reasons, but what are the some reasons that NSAIDs or these non-steroidal anti-inflammatory can cause these issues? So I'm going to look here at my chat for a few minutes. So very quickly, just so that I don't take too much of your time, of course, these are cyclooxygenase blockers, and they are prostanoid blockers. So what happens is that when we have these molecules blocked, the stomach's lining and the bicarbonate production in the stomach. So stomach has a lot of hydrogen or protons produced, right? Acids produced. So stomach also then produces a layer of bicarbonates to kind of neutralize these acids and keep them in check. Similarly, the mucosal lining of the stomach also have other molecules that are present in there that would kind of neutralize the acids which can attack the stomach's own mucosa and stomach's own tissues. The NSAIDs, non-selective NSAIDs, number one, cause reduction in those protective molecules. And number two, they cause reduction in the production of bicarbonates. Number three, this is really important, because they cause vascular vasoconstriction and they can give rise to more clotting as well. The vascular constriction on chronic basis, if we are giving this drug to people on a chronic basis, can cause ischemia. So the stomach ulcers are not only because the bicarbonates are less and the protective enzymes in the mucosa are less, and so the acids are digesting the stomach and causing pain. It is actually the blood vascular system as well that has become now, the vessels have become constricted, which reduce the blood flow to the stomach's lining and the tissues, which then cause ischemia, which then ends up in the chronic ulcers. Similarly, in the renal tissue, the glomerular filtration reduces, water and salt retention occurs, blood flow actually reduces to the kidney because of the vascular changes that are brought about by NSAIDs, causing pressure on the kidney. And if a person already has a kidney disease, then their kidney can actually become damaged because of the chronic NSAID usage. So here, if we can very quickly see, gastrointestinal tract, erosions and ulcers of gastric mucosa, nausea, vomiting, bloating, diarrhea, constipation. Renal side, reduced glomerular filtration rate, sodium and water retention, pitting edema, hyperkalemia, kidney failure, interstitial nephritis. Now think about it for a second with me. When there is sodium retention and water retention, that would increase the volume in our body, that would cause hypertension. So now the NSAIDs are causing vascular constriction, which would cause hypertension, plus they're causing sodium and water retention as well, which would also cause hypertension. So if somebody has cardiovascular compromise, if their cardiovascular system has some pathologies already present, and if they're using NSAIDs on top of that on a chronic basis, it is possible that the likelihood of cardiovascular events would increase. The risk of cardiovascular events would increase in that. Not only just that, the thrombosis, the tendency to thrombose increases as well. So here, cardiovascular events, thrombotic events, increased blood pressure, congestive heart failure, tachycardia, palpitations. Then central nervous system, headache, fatigue, insomnia, vertigo, seizures, and then other bleeding, asthma attacks, Reye's syndrome, urticaria, neutropenia. What I'll do is this. For the NSAIDs cardiovascular effects, I'll do a separate talk and just create a video for exact mechanisms for how that happens. But please keep in mind that the ceiling dose for ibuprofen, for example, 400 milligram for analgesia, above that, lesser analgesic benefit and more risk, more likelihood of the cardiovascular events. Any questions, comments so far before we continue? Okay, excellent. So then are the anticonvulsants. Anticonvulsants. I'm sure that you know this thing, but I think you'll enjoy this. Anticonvulsants are some of the anticonvulsants can be used as a first-line drug for neuropathic pain. And when a patient has pain syndromes, where they have pain, for example, let's say there is peripheral inflammatory pain, and then there is a neuropathic pain that has become part of that pain as well. And can I uh, ask you to jog your memory to think about how the neuropathic pain would appear when there is a peripheral pain that is occurring? We have done this discussion before that when there is peripheral pain and there are more cytokines and the pain related mediators that are circulating in the body fluids, the sensory ganglions, they are not as much separated from the circulation and the components of the blood circulation as the blood-brain barrier is. So these mediators would actually have access to the sensory neurons present in the sensory ganglions. And over there, when the sensory neurons are irritated because of these mediators, then the neuron would start producing ectopic stimuli. Those ectopic stimuli would send central signals, which would cause pain or paresthesias, plus they would send the peripheral signals, that is the pain would actually, or the signal would actually travel from the neuron cell body all the way to the periphery where the receptor is. And the receptors, the sensory receptors, the free nerve endings, for example, will start releasing substance P. And the substance P will in turn cause inflammation in the local area. So now we have a neuropathic pain component added to some other inflammation, some other inflammatory state. And so now we have a syndrome of pain where we have pain because of some inflammatory state and we have neuropathic pain component added to that. So if that is the kind of situation, then anticonvulsants can be used for the neuropathic pain component as a first-line analgesics. So here, the examples are gabapentin or pregabalin, originally developed to treat seizures, these anticonvulsants. However, these are commonly used to treat various pain syndromes such as post-herpetic neuralgia, shingles pain, peripheral neuropathy, and migraine. And peripheral neuropathy, I just gave you an example for that, for the mechanism. And this mechanism, I believe I had discussed at maybe second or third pain lecture in this series. Now, pregabalin is approved for fibromyalgia as well. Some of these agents are effective in treating the neuropathic pain component of a pain syndrome. Pain syndrome would mean multiple reasons for the pain coming together to create that pain, and then we have neuropathic pain. The harm of this, or the side effects: sedation, dizziness, ataxia. CDC called it harm, so that is why I wrote it. Let me just very quickly show you that when CDC wrote it down, they said harms. So if you see here, medication, magnitude of benefit, harms, and then comments. So if you see here, gabapentin and pregabalin, harm, sedation, dizziness, ataxia. Why do I give you references? Why do I bring receipts? It is important. These are CME lectures, and I want to make sure that everything is here with the reference, and there is lesser of my opinions here. Okay, continuing. Antidepressants. So commonly used in various chronic conditions. And let me back up for a second. If you said that what is the source of these messages if we have to go to one place, then I would request you to look at this pain management best practices. This is a beautiful, exhaustive, thorough book. And in this book, not only they have talked about various pain management interventions possible, therapies possible, but they have actually given various case reports as well. They've given examples of various people with various kind of pain syndromes and then the approach to managing their pain. So it's a beautiful book. So back here, antidepressants. Commonly used in various chronic conditions, tricyclic antidepressants are effective in neuropathic pain. So if you're going to use TCAs, tricyclic antidepressants, then what you do is that you initiate at a low dose and then titrate that upwards according to the patient's response. So initiate at a low dose trial with different tricyclic acids, and then gradually titrate to optimal ends. So desipramine, nortriptyline, amitriptyline, etc. Then there are SNRIs as well, serotonin, norepinephrine, reuptake inhibitors. These are venlafaxine and duloxetine are effective for a variety of chronic pain conditions, including musculoskeletal pain. Again, they're talking about chronic pain, not, acute pains, fibromyalgia, and neuropathic pain conditions, but have markedly fewer adverse effects. For example, lower risk of drowsiness, memory impairment, and cardiac conduction abnormalities than TCAs. So these are SNRIs. Risks and adverse effects: dry mouth, dizziness, sedation, memory impairment, orthostatic hypotension, urinary retention, cardiac conduction abnormalities. Let me back up for a second and just very quickly make a comment. The benefit of this presentation is that I scoured through all of those recommendations and then collected their summary and put them in one place to create the cocktail that is available for us. So that is the benefit of today's talk. Musculoskeletal agents. We all have used musculoskeletal agents for our patients or ourselves. They can be used in acute setting or chronic settings, commonly used for pain treatment. Examples are baclofen, tizanidine, and cyclobenzaprine. Now, there is one that is the carisoprodol. It is not recommended, but I wanted to quickly read this one. So this paragraph is from Florida's recommendations. So Florida said about the musculoskeletal. So medicated creams, foams, blah, so can be safe to relieve mild to moderate pain. I actually want to make sure that I am looking at the correct one. Yes. Can be safe to relieve mild to moderate pain because medication is applied where the pain is. This is also topical. Anesthetic relieve nerve pain, shooting and burning pain by numbing an area. NSAIDs relieve the pain of osteoarthritis, sprains, strains, and overuse injuries. Muscle relaxers reduce pain by causing muscles to become less tense or stiff. And capsaicin relieves musculoskeletal and neuropathic pain. Compounded topicals prepared by a pharmacist can be customized to meet a patient's specific needs. Skin irritation is the most common side effect. Capsaicin can cause warmth, stinging, or burning in the skin. Then is the interventional pain management. And this is a huge area in itself. It includes the ganglion blocks, and it includes the nerve blocks and many other kinds of procedures. And these procedures require specialists to do them. So some examples of the interventional pain management refers to a group of minor or major surgical procedures that can be used to control acute or chronic painful conditions. These include, but are not limited to, trigger point injections, different nerve blocks, intravenous infusions, radiofrequency lesioning, botulinum toxin injections, intraspinal analgesics, and spinal or deep brain stimulation techniques. Specific training is required to perform each of these type of procedures, not only with respect to the procedure itself, but also with respect to the management of potential complications of the intervention. Interventional pain management procedures are often an important component of a comprehensive pain treatment program. Then are topical agents. These, again, we have all seen them, used them, or used more than what are present here. Lidocaines, capsaicin, NSAIDs, consider as alternative first line. This is very important to keep in mind. And again, I am not assuming that you do not know these things. Pain management and pain, our encounters with the pain are the very first thing of medicine. So the topical use is considered better because the systemic use may have other side effects. So consider as alternative first line, considered safer than systemic medication, lidocaine for neuropathic pain. Topical NSAIDs are for localized osteoarthritis, topical capsaicin for musculoskeletal and neuropathic pain. So musculoskeletal pain, capsaicin. The osteoarthritis type pains, NSAIDs. Neuropathic pains, lidocaines. But once again, please keep in mind that these are pain relievers. They are not going to remove the pathology. They're just going to help patient handle the pain. Now, there can be a capsaicin initial flare that would create burning irritation of mucous membranes. Now we go to the American Anesthesia Association and their recommendations for non-opioid treatments. The link is down here. So physical therapy, a physical therapist or physician who specializes in physical medicine and rehabilitation may be able to create an exercise program that helps you improve your ability to function and decrease your pain. Whirlpools, ultrasounds, deep muscle massages may help. So that's one. Acupuncture. So I would remind you that the Florida recommendation did say it on top of their page, and that is some of these may not be covered by insurance and they may not be as effective for severe pains. So acupuncture, you may find relief from acupuncture in which very thin needles are inserted at different places in your skin to interrupt pain signals. Surgery. When other treatments aren't effective, surgery can be performed to correct abnormalities in your body that may be responsible for your pain. Injections or nerve blocks. If you're having muscle spasm or nerve pain, injections with local anesthetic or other medication can help short circuit your pain. So stellate ganglion blocks are very common nowadays in long COVID patients with autonomic symptoms. Radio waves, nerve blocks, electrical signals. Then spinal cord stimulation. When other methods fail, a pain medicine specialist might recommend spinal cord stimulation, which uses a pacemaker-like device that replaces the pain with a more tolerable sensation. They create paresthesia. And we have seen this. You may have noticed this. I think I discussed this phenomena in 4th or 5th lecture, where we discussed that pain can become masked by other sensations from the same local area. This is why when somebody has pain, they try to press on it, they try to grab that area, they try to rub that area, they try to scratch that area, because other sensations kind of reduce the sensation of pain. So here they install a pacemaker in the spinal cord or with the spinal cord that would produce stimulation of other sensations to mask the pain signals and to mask the feeling of pain. The physician implants a device in the lower back, attaching it to tiny wires that are located in the spinal canal. When patient feel pain, they can use a remote control to send signals to the painful area. This technique can help with back pain as well as neuropathy, nerve damage in the legs that causes numbness and pain, which is common in people with diabetes. New forms of spinal cord stimulation show promise in relieving pain without tingling. The tingling is a paresthesia. It can happen with the nerve compression as well. Then are the pain pumps. Special pumps can be implanted to allow a patient to push a button and deliver pain medication to their spinal cord, bringing relief without the side effects that often come with the taking these drugs by mouth. And then other future solutions. One of the most promising research area involves harvesting stem cells from a patient's bone marrow and injecting them into an area such as the lower back that has become painful because tissues have deteriorated. The hope is that the stem cells will build new healthy tissue and relieve the pain for good. And I want to give you an example. I know that this is a CME lecture, but I think this example is interesting. When I was visiting Mayo Hospital in my tour, the plastic surgery assistant professor over there of the plastic surgery, he was quite creative and innovative. He had actually invented many of the plastic surgery devices as well. And he said that he has become popular for injecting stem cells in various joints to reduce joint pains. And he says, I have lines of people who are now waiting for me to do this intervention. So once again, from the US point of view, I'm just discussing an intervention done internationally, and that may or may not be approved over here. Now, more ideas. So the further possibilities are, number one, self-care. I was talking about the hot and cold, and what is the logic behind asking someone to heat the area of the pain and swelling, or to put cold uh, swabs or ice or other cold things. If as a physician, as a provider, you are looking for the area of the pain to have more fluid, more blood circulation to come in, so that you can bring in more nutrients over there, so that you can bring in more reparative cells over there, immune cells over there, and you can help take away and clear out the toxic substances that are building up, and the dead tissue and the debris and the macrophages that are building up. Then what you would do is you would ask the patient to heat the area, which would increase the blood supply and circulation in that area and kind of bring in more healing forces of the immune system and take away more of the debris. However, in an area of active congested inflammation, where the inflammation is already there and congestion is already there, increasing the blood flow might actually aggravate the situation a little as well. Now, on the other hand, if you are looking to reduce the blood flow to an area, you want to reduce the pain in an area and inflammation in an area by reducing the blood flow, then you would ask them to use ice packs or ways, whichever way they can cool down that area. So cooling it down, for example, imagine that there is a patient who has triangular fibrocartilaginous complex. So let's say over here on the back of their hand, they've gotten some sort of a injury to their tendons, and now they have ended up with a complex over here that is just sitting there and it's not recovering, and the patient has pain and it's just continuing, and there is low grade inflammation that is just persisting. So in this kind of a case, you could ask them to use cold, various cold packs or ice to reduce the inflammation in that area, to allow the inflammatory cells to move on from there and let the tissue heal and not have persistent pain. I mean, that is just one possibility. Ice or heat doesn't always fix the problem, but this is one part. So cold and heat. Ice relieves pain and reduces inflammation and swelling of intense injuries. Heat reduces muscle pain and stiffness, can provide short-term and long-term relief from pain. Too much heat can increase swelling and inflammation. So I just mentioned the mechanisms for why that happens. So this is the logic behind ice and heat. Then exercise and movement. Regular exercise and physical activity can relieve pain. Simply walking has benefits. Mind-body practices like yoga and Tai Chi incorporate breath control, meditation, and movement to stretch and strengthen muscles. Maintain daily exercises, and overcoming barriers to exercise can be a challenge. Then complementary therapies, for example, acupuncture, chiropractic visits, osteopathic manipulative treatments, massage therapy, transcutaneous electrical nerve stimulations. Then is the rehabilitation therapies, for example, occupational therapy. Occupational therapies treat pain through the therapeutic use of everyday activities, can relieve pain associated with dressing, bathing, eating, and working. Therapy includes activities that increase coordination, balance, flexibility, and range of motion, but the patient has to kind of repeat them and practice them, and that is how they would help them. So Dr. JP Sleeby is saying metaxalon, or as known as skilaxin, dual function as antispasm and analgesic, and tricyclic antidepressant as pain modulators, example amitriptyline, and many others in this class can be considered. Cannabinoids can also be helpful. Low dose naltrexone, VLDN, once or twice daily, and in combo with CBD. So some parts of this from a CME point of view may not be the overall recommendation. So I just read what Dr. JP Sleeby wrote. That doesn't mean that I'm saying that this is the CDC's recommendation. Behavioral and mental health therapies. So psychiatric, clinical, social work, marriage and family therapies, and mental health counseling. And now here are the references. And thank you very much for your time.